once again to the RxDX Pathology YouTube channel, and here I'm Dr. Anjat. I'm going to discuss one more important case here. So I'll not give away the history directly. Let's assume it's a skin ulcer. I'm sure you can see the squamous epithelium here, and I'm not actually going to reveal the site of the skin lesion because that might sometimes give away the diagnosis. Let's go into the case thinking that it's of a blank spotter. I want you guys to keep on thinking, refining your diagnosis as and when I show you some important findings, right? Let's zoom in first of all. Definitely it's a skin lesion. You can see the squamous epithelium here. That's a beautiful row of melanocytes, and you can see sebaceous gland stuck to it right at the bottom of it. So when you look at the squamous epithelium per se, it's not much of a trouble. It's looking decent, not much of ATP and everything. But definitely when you go a little bit here, you are definitely having an ulcer, right? So whenever you see an ulcer, always don't think of an infective etiology nor rule out infective etiology. Both, everything should be kept in mind because even a breast cancer can present as an ulcer, right? A Marjolin's ulcer is an ulcer, right? So there are many things which can happen as an ulcer, not just an infective etiology or a diabetic foot ulcer. At the same time, whenever you look at any ulcer, the topmost part of it will have collection of neutrophils, will have necrotic debris. That is part and parcel of the game. This might not be the pathology, underlying thing might be the pathology, right? I don't want you to overlook and saying that okay, I'm seeing lots of neutrophils here. Definitely you see neutrophils, you see exudate here, so it's just a neutrophilic ulcer, let's go for a culture sensitivity. Don't do that, because the topmost part of it, like I said, most of the time will have the same thing. It will not change because an overlying tissue, it will react, it will have bacteria, it will have infection for sure, right? So if you see, is there any underlying pathology or not? For that, the best thing is obviously to go to low power. You see this low power, you can see a squamous epithelium here, you have an ulcer going here. Till this, there's some problem, right? Because here you can see the collagen of the dermis, and here you can see the glands, and here you can see the broken subcutis maybe, right? So there is good amount of pathogenesis going on in this area, so it's less likely to be an infectious ulcer, right? Let's zoom in a little bit. Second thing which I want you to go when you little bit zoom in is there any granulomatous lesion, is there any giant cell, is there any fungus, is there any bacteria, is there any hint of infection there, right? One thing what I can see in this power is it's more pink in color, right? Generally when I see a more pink color, we tend to move away from a neoplastic lesion, right? It's always been said that more blue it is, more cancer it is, because of the high MC lesion and anything, right? Let's go and look into it a little bit deeper. Again, like I said, yes, there's lots and lots of pink color here. If you look at the cytoplasm of every cell here, maybe here it's more clustered, don't look at that. Look at this part. I have a nuclei, you have a decent amount of pink cytoplasm surrounding every nuclei, and there's a little bit of inflammatory infiltrate here, and again the same thing here. So this is unlikely to be a infectious cause because you have a group of cell which is not exactly looking like an WBC, right? Or an infectious cell. But yes, there is a possibility this still could be a WBC. I do have a little bit of vessels here, dilated vessels, infectious, sorry, WBC is there, ignore them. That's part and parcel of the stromal reaction, right? Now let's zoom a little bit more here. If you look at this, these are dermal fibers. You can see the collagen fibers there. But again, like I said, I do have a good amount of eosinophilic cytoplasm, right? So whenever you see a dermal lesion with such an eosinophilic cytoplasm, right, a cell with an eosinophilic cytoplasm, I want you to look into the background as well. What are these? I do have tiny bit of eosinophils here and there, right? I'm sure most of you must have kind of made the diagnosis here, but let's zoom through. Let's skim through a few more areas. I'll show you the classical findings in this case. Let it give me a second. Yes, let's go through this area. I feel I do have lots of cells here which is a little bit splayed away. If you want to talk or look or appreciate the nuclear features of any lesion, I want you to go to a place where it is little bit splayed, little bit moved away, right? If it's very cohesive, very clustered, then sometimes you might lose the nuclear and the cytoplasmic features, right? Let's zoom in here. Let's zoom in here. You can see that the cell has a very vesicular nuclei, prominent nucleoli. Some of them have two prominent nuclei, some of them have one prominent nucleoli. But yes, around every cell, you do have a decent amount of pink cytoplasm. Let's focus here. If you look at this cell, it's kind of intended, it's kind of bent, right? It's kind of bent here, right? I'm just looking for the characteristic cell here because I obviously know the diagnosis of this patient. Look at this, that's what I'm looking for. Can you see this guy? A horizontal line. Yes. Does it ring a bell? Maybe. Does it look like a coffee bean? This one here, this one out here, this one out here. See, the thing about coffee bean nuclei is once you notice one coffee bean nuclei, many more things will keep on coming, right? That's the thing about coffee bean nuclei. Yes, they do look. There's a beautiful coffee bean here. It actually looks like a coffee bean, right? The see a horizontal groove. The groove here is very characteristic. Here again a groove. Here again grooves. There are multiple grooves, right? Like I said, once you look at one coffee bean, it keeps on flowing easily. But looking at the first coffee bean is always very tricky, right? So I'm just zooming out here for a quick wrap up here. I want you to think of whenever is a question which comes to you or in a real life or an exam with a non-healing ulcer in the back of the head in the temporal area of a child, Langerhans cell histiocytosis should be one of the differential diagnoses, right? So if you look at Langerhans cell histiocytosis, just a little bit of a theoretical part, it is moved from the older ones of Letter-Sweep syndrome and everything to a single system Langerhans cell histiocytosis, skin, bone, and pituitary. Like I said, temporal region is very commonly involved because of temporal bone and the skin overlying that, right? And also can be multisystemic. Multisystemic is generally deep involvement. Liver, spleen, lymph node can also be involved. Single system will have an osteolytic bone lesion. So when you have a OSCE pattern question with multiple punched out lesion in the skull of a child, always think of one of the differential diagnoses to be LCH or Langerhans cell histiocytosis, right? Histologically, you'll have large histiocytes, grooved eosinophilic cytoplasm. You might have eosinophils, lymphocytes, and giant cells. Generally, we always been pushed saying that Langerhans cell histiocytosis should have eosinophils in the background. If you look at this patient, I do have eosinophils, I'm not denying that, but I do have good amount of lymphocytes also. I do have good amount of lymphocytes, little bit of eosinophils, actually more of lymphocytes, right? So it's not a dictum for you, though it is predominantly seen. It's not a dictum that I should see only eosinophils. You can see multinucleated histiocytes, lymphocytes, and also eosinophils. At the late stage, you can have a fibrosis in the background because obviously it's an histiocytic lesion. You can have a fibrosis, right? I want you to think of anywhere when you see histiocytic collection, especially when it's the skin, please look into the nuclear details carefully. That's very important. Without that, you might miss this patient, right? I want you to comment in the below section if you have come this far. Please do comment. It's just a positive motivation for us. Tell me one more marker apart from S100 and CD1A which can be useful in this patient, and also if possible comment on the electron microscopy. See you soon. If you're not subscribed, click the subscribe button. Let's learn more together. Bye bye.